welcome back to episode 63 of the Sports Medicine Project, the intro to the intro to our part one with Dr. Peter Malliaras, the tendon guru. Now, Kelly and I went on somewhat of a good conversation for the first 45 minutes, so skip straight to minute 45 if you want to get straight into Dr. Peter Malliaras' episode. But what we talked about were a couple of listener questions, discussion on recent advantages in tendinopathy, the current understanding of the continuum, efficiency in clinical life, return to racing post-shin splints, running injuries, rehab fatigue, and when to discharge people, plus a couple of case studies. But enjoy, guys.
Of the Sports Medicine Project, number 63 we are up to today with Dr. Peter Malliaras, the tendon guru, some may say.
I say that, definitely.
I think everyone says that.
Yeah.
I don't think there's many people that don't say that.
No, he's incredible. He is such a knowledgeable guy and answered the questions. It felt like it was really simple, but the topics he was talking about. The topics he was talking about? That doesn't make sense.
Topics he spoke about.
Yeah. That just sounded really illiterate. But yeah, the topics that he spoke about are incredibly complex topics, but he explained them so simple, as in, I'm excited for patients that I see to listen to this, for them to get an understanding of what we talk about in the clinic.
And you can tell he is a presenter because he just spoke very well, exactly what you said, explained complex things in a very digestible way. Yeah,
it was great. And, you know, when we had Dr. Rich Willey talking about bone stress injuries, I mean, I see tendinopathies more than I see BSI injuries. Tendinopathies are a mainstay of anyone's clinical diary. I mean, if you're a clinician, it's guaranteed. You may not see a bone stress injury every day, but I bet some money you'd be pretty close to seeing a tendinopathy every day.
Yeah, particularly working in a sporting-based private practice.
Yeah, even really...
Or athletic, recreational.
Yeah. I don't even think that would be the case. I think it happens in all the
general
population.
Pop.
Yeah, I would see more tendinopathies in the general population, and not just active people, but post tendinopathies, Achilles tendinopathies, perineals, those kind of things. Almost even a bit of plantar fasciopathy. That's almost treated somewhat like a tendinopathy.
Yeah,
but it does happen to everyone. I know there's risk factors for, the more that you do because of the more mechanical load that you apply to the tendon, but it really does happen.
But then in more sedentary populations, because their capacity to tolerate load decreases, if they go and do a lot of gardening one day or go for a walk with their family one day and they haven't done that in years, then that's an increase in load that could set off a reaction of the tendon.
Yeah, and as you get older, you get changes in the cross linkages between your collagen, which can also affect the ability of the tendon and muscle to produce load, which can inherently reduce its capacity. And sarcopenia, which is a loss of muscle. I wonder how that would affect. I know it's in the geriatrics topic that I teach. There are so many age-related changes that happen, and tendons are the ones that tend to get affected amongst everything else in the body. Yeah. On that topic, actually, so we'll talk about what we're going to talk about today. So obviously part one with Dr. Peter Malliaras, but what topics are we running through today, Kelly, sub 140 half marathoner?
We've got some listener questions that we'll go through.
Yep.
Which include some of the recent advances of tendinopathy, our current understanding about the continuum model and its relationship to load. There was another listener question as well.
I put him into.
Okay. Yeah. There's also a listener question on the role of isometrics with tendinopathy. We've got some case studies about returning to racing post MTSS, running injuries. How do we translate research to clinical practice? Talking about rehab fatigue and when do we have a rest from rehab? I'm keen to talk to you about that one. Those two topics.
Yeah, and efficiency in clinical life, because we know the majority of people that listen to our podcast are clinicians, healthcare professionals, and we really want to try and explain the things that we've seen. We try to implement ourselves in our clinical life, not just related to treating patients, but things like financial health as an allied health practitioner, business-related content, and also how we manage as practitioners just in the day-to-day life, like time management, rebooking, that kind of thing.
I'd say you and I are very different in that space too.
Which is good.
That's what I mean. Like, it'll be a good... differing perspectives, I guess.
Yeah, and if we do have any new listeners, Kelly and I are partners. We love to agree to disagree. Is that right? And we definitely have varying perspectives on lots of different things. We probably agree a lot on the knowledge, like do bone stress injuries need resistance training? But there's these little nuances that we both have, which is another reason why we created the podcast, because there isn't anyone, I don't think you'll ever find a practitioner that solely treats the way that you do. Definitely believe in the principles, but you're never going to find someone that's completely similar, which is good, which is really, really good.
I had feedback from a runner that I was running with today who listens to the podcast. He said that our debate and bickering adds a layer of depth to the podcast that you don't get in many other podcasts. So
yeah, and we're allowed to do it. And
hear.
Also, we know that polarizing content, not to say that you and I are bagging on each other all the time, but polarizing content psychologically is more engaging for people. Like, we know that with the spread of social media content, we know the spread with fake news when it comes to politics. For an example, someone posted a picture of something that was happening in a Facebook group that I'm a part of, and they were saying there was a debate going on. As soon as I saw it, closed it, went straight to the group to read it, whereas they just posted something otherwise, I probably wouldn't have done it. We're kind of drawn to that as
drama.
Human. Yeah, we're drawn to it. That's why we love Grey's Anatomy. But let's get started. I'm going to start off with my week and something that I've tried to implement. Had a really busy week, and it's been busy the last 2 weeks, and I really put the hammer down this week and tried to focus on not getting distracted at all, and just always, any time that I had, trying to get my notes and reports done. So if a patient left a couple of minutes early, or I had someone move to a bit later, or someone reschedule, wouldn't pull out my phone, wouldn't talk to anyone. I'd just go straight to my notes and try and get them done. And it was so much better. Like, you even think, and I was playing this little game, and I remember I had 3 notes to do from the morning. It was 11:57, and I had another patient at 12, and I was like, can I get my notes done? And I should be able to, if you really just focus for a minute, and you can get patients' notes done.
Long.
They don't. You've just got to
mentally,
you just got to do it. Just start doing it, and it just flows. And obviously, I'm not taking, for review appointments, I don't take as detailed notes as if I was doing an initial, but you really can get it done. So, and it's easy to get distracted. I want to pull out my phone. I think of something I want to write and talk about the podcast. I want to go and talk to someone. Yeah, but try that.
Did you try, I've got a question. Did you try conducting an initial consult without taking notes and just listening?
No, I didn't, but I made sure to, and I always do that anyway, I made sure to really make as much eye contact as possible. However, this is what I realised, and maybe from that, this is what I realised I can do now. I can take notes without looking. I've got enough, because I've got the same keyboard at home, because I'm writing research and content for the podcast. I do a freaking lot of typing. I can take notes without looking. So I tried that, and it was pretty accurate. A couple of spelling mistakes, which was fine, but I can look at them and just take content.
I think that's still the same thing though, where your mind is not focused on them.
But I wouldn't say it's taking up any of my cognitive bandwidth by hearing what they say and me just typing it. Same as like walking. Can you speak and walk?
Yeah.
Yeah, but I could be wrong. Maybe it's distracting for the person sitting right in front of me though.
I don't know.
But no,
I don't want to talk about this though. I was just curious.
Right, but I didn't do it to the extent that you said. But that was something I want people to try and do, is just focus on just getting your notes and reports done when you've got those time gaps, even if you go 10 minutes into lunch.
Good one.
I had a wound come in at the start of the week on Monday, and we don't see a lot of wounds in the clinic. We really don't see.
How intense would you say this wound was on a scale of 0 to 10?
Yeah, pretty intense. I recommended the person to go.
Like diabetic wound?
Not diabetic, but there was definitely infection and things present, which I'm not going to talk about diabetic foot ulcers or just foot ulcers in general, but as soon as I saw that, like, I'm comfortable in managing them, and that's one of the topics that I teach at the university. Debridement, dressing, offloading, education, those kind of things are all important. But I am not I don't believe that I am the best practitioner to manage this presentation. And I explained that. I said, this is what we see. I'm very happy to manage this. And I knew that it was a family member who mentioned for this older person to come and see me. Like, I'm very happy to manage this, but I have a colleague who's a lot better at managing this, probably more well equipped in regards to dressings and offloading. So I think it's probably best that you see them, not to shush them out the door, and not that I don't want to see that. There's just someone better at it, at managing it than me. What do you think of that?
Yeah.
What
did they do?
They're staying with me. They're like,
I feel like that always happens.
Yeah.
I every time I have that conversation with people where I'm like, there's probably someone better to see this if you want to go and try with them. Like, for example, I can't even think what an example would be. But, yeah, I find more often than not, they are like, oh, it's all right, I'll stay with you. I'm like, okay, if you want to.
Yeah. And, I'm not saying that you should do that as a practitioner. This is just my personal preference. And when it comes to these things, they're in a high-risk area on the end of the toes. So, yeah, it was just something that I thought that would be worth mentioning, because I know that would happen in clinical practice. And I know the saying goes, if you're a young practitioner, you want to get exposed to as many things as possible so you can become quite fluent and quite generalised, so you're prepared for anything that comes in. But in this case, I was confident and I knew what I guess I wanted to say, and they were appreciative of that. Have you ever had that happen? What would be a physio example?
I have, and I can't think of what it was. I'm thinking it might have been something women's health related. Yeah. I think what it was someone coming in to see me because I've expressed an interest in working with females, and I think from that they thought that I was a women's health expert, and I had to sort of explain to them, look, no, I can do a general sort of pelvic floor assessment and give you advice and recommendations on things that you might be wanting to work on. But if you're looking for a more in-depth women's health assessment, these are the people that I'd recommend you go and see. That's their field. They're the experts in that field. And they were like, nah, it's all right, we'll just try this first, and if I feel like I still need it, then I'll do that. I'm like, all right.
You think, like, what's best for the patient? It's going to be better that the patient sees someone that sees it more often. I mean, can I manage someone's glute tendinopathy? I probably could, but I know there's a lot better people well equipped out there than me.
Yeah, and if it was something very significant, I would have definitely suggested that. I think for this person, it was just like a bit of incontinence when they were running or something like that. Yeah. And I just said, well, we can try a few of these things first and see how you go, and if you need to, then one other, well, two interesting patients this week, and it's always, as we always say on this podcast, it's always very rewarding to see people, especially when they do something that you love and you enjoy. I'm talking about running, but two patients who are just such lovely people, almost back to 100%. And if you listen to this podcast consistently, you would have heard myself talk about a recent insertional Achilles runner that was a little bit, not odd, but it didn't fit into the tendinopathy box that we would expect. So insertional Achilles, we would expect more faster running to be irritable, and it wasn't. So I was saying the other thing. Sorry, we would expect more elevation to be more irritable, and it wasn't. But anyway, saw this person this week. Comes in. How have things been? Great. Feeling good. Really not really much pain at all. A little bit of morning stiffness, but I'm feeling really confident. Went for a 3-hour long run. Like, everything was going really well. Like, great. That's awesome. Now, when I was a younger practitioner, I would have been straight along the lines of, great, awesome, don't need to see me again, fine, keep up with the rehab, if there's any issues, re-engage. But now, seeing it enough and having probably, not failed care, but people come back and re-engage, I just said, that's really good that it's like this. However, we know with musculoskeletal injuries, they don't follow a nice linear equation back to 100%. And although things are going really well, there is always the chance that it could flare back up. So a revolving door, as Peter Malliaras
would say. And that's really good sorry, you put me off track there. Sorry. It's good that things are going really well. However, if things were to flare back up, still using the same management strategies that we talked about, and I still want you to continue with the rehab, yes, the rehab can start to take a little bit more of a backseat, and you can start to increase building up your running. And I've said this to this person's coach, and yeah, I rebooked this person for 3 months, and I'll check back in, and then I'll give some more rehab and make sure things have been okay. But it was an interesting insight and reflection to, although things can be going really well, don't jump the gun too much and say, great, you're out of the woods, that's awesome, because we know these things can flare back up again. That's the nature of MSK injuries, and you've got to explain that reality with your patients.
I think it's good to pre-frame that also, because in the chance that it does flare back up again, they're prepared for it a little bit more, and you've had that conversation with them, and I think it minimises their concern around a flare-up as well. So if it happens, they're like, oh, well, that we discussed the chances that could happen. It's not the end of the world. It'll be okay. It's just having a little moment, and it'll get back on track again. Yeah,
and then so another runner as well that I saw around Christmas, and I posted this on the Instagram story, this person was only able to tolerate 3 by 6 minutes of running. Saw this person this week, and they're now up to 3 times 60 minutes of running. And
3 times 60 minutes?
Yeah.
Running
so
for 3 hours?
Oh, not like over the week.
Oh,
yeah.
It's like, wow, that's a lot.
So, and when I originally saw this person 2 weeks prior to the first appointment, they couldn't walk. They had to completely stop running. And it just goes to show those flare-ups can really have such an effect on someone, but they can recover quite quickly. And one of the things that I reflected on as well was when we're going through their return to running, I explained that the body does not follow a linear equation where it just goes up and up and up and up and up to 100%. You can have down times, flare-ups and bad days, or you can have really good days. Because, yes, there is the chance that it could flare up, but there's also the chance that it might improve quicker than what we're saying. So if it feels good, it's okay to push it, knowing that it might get sore, but you're not going to do any damage. And they just continued to push it, and it got better like a month earlier than what we'd expected.
It's scary for patients, I think, to take that leap of having enough trust in you and themselves to just go for it a little bit. I think that takes a lot of confidence to really get to that point. So that's cool though. I agree.
Yeah, it was awesome. So what about your week? You've got some topics to discuss.
Yeah, I wanted to ask your thoughts on when patients have been going through rehab for a long time and they're often thinking about their injury, and their injury becomes their sole focus almost throughout the day. At what point do you think it's a good option for them to take a step back from rehab, or do you think that's going to derail their progress?
I've got a few more questions. Is that from because it's painful, or because it's limiting their activity, or the injury's like not getting better, or it's just taking a long time?
Just taking a long time. Maybe their expectations weren't set right at the start, and maybe it's going on for longer than they expected. There's a bit of rehab fatigue because they're waking up in the morning, having to do their exercises to, let's just say, so a patient that I'm thinking of in particular is, I've got 2 patients actually that I'm thinking of, but we'll go with the one who had a knee replacement. And she has to wake up every morning and do her exercises just to minimize some of that stiffness and soreness that she gets in the morning. And then throughout the day, she is thinking about her knee because it just doesn't feel normal. It doesn't feel like she wanted it to at this point in time. Do you think it's better to continue to push rehab, or do you think it's better to almost tell them to take a break in some senses?
Yeah, that's a great question, and I don't think I'm going to have the answer, but I definitely have some thoughts on that. Is it purely just the feeling of and you could obviously extrapolate this out to any injury, but is it more the feeling, or is it trying to get back to something just because it feels different?
So this patient in particular, her knee was feeling pretty good before the knee replacement. And I was almost encouraging her to try and delay the knee replacement without saying that, but maybe suggesting that that's an option because of how well it was feeling. And then after the knee replacement, it felt really bad and sore and stiff, and now she doesn't have the range of motion that she anticipated that she would. She hasn't gone back to some of the activities that she thought she'd be able to by now. The other element is she's quite a perfectionist, so she's always asking me to measure her knee flexion, and she's so determined to get it to 130 degrees of flexion, despite my best efforts to say where it is at the moment at 123 degrees of knee flexion is okay. You'll be able to do most things. Yeah.
It's hard. And that's a really common scenario that happens for a lot of people. And it's through no fault of patients at all. I mean, they just take in the information from different practitioners and they ultimately make the decision. But I don't know, and I don't want to say that people get knee replacements and surgeries and things unnecessarily, but it seems to definitely happen. And yeah, we know that surgery is varied. So I do want to say it's obviously not from any patient fault, but yeah, I don't really know how to answer that. I mean, is it all you can do is have the conversation and try and create and instill that idea in that person, but do you feel like you're getting anywhere?
For what I've done for her, because I actually think that she's got a reasonable amount of function. So for her, what I've done is said to continue to do the things that make it feel good each day if you feel like you need to.
Yeah.
Other than that, I only want you to complete your strengthening exercises 2 times a week. The rest of the week, I just want you to do the things that you like to do. So yoga, walking, going to the beach, going for a swim. Think of it as your normal activity, not as rehab. I don't want the idea of rehab to be in your head anymore, really. That was the advice that I kind of ended up giving her when I saw her last week. And
so shifting the focus.
Shifting the focus away from rehab.
It's not painful, it just feels different and stiff.
Just different and stiff and not what she was hoping for. Yeah. Then I've got another patient, which I would say is a similar scenario. She had a really big surgery last year, and prior to that was going through a year or so of rehab before the surgery, then had the surgery, and it's very painful and very functionally limited still. She can't do a single leg calf raise and it hurts a lot. She has significant, I would say, rehab fatigue as well, in a different sense though. So I think she has a lot of functional limitations, and this is one where I think she needs to continue to do rehab maybe, but I'm aware of the rehab fatigue that is affecting her as well.
Yeah, that's hard. I don't have an answer for that. But if the rehab is important, do they need the rehab?
I don't know. I guess so. I mean, I think if you can't do a single leg calf raise, that's a problem. Yeah,
I agree. I mean, shifting the focus, trying to change the narrative. I mean, it's definitely about someone's belief that you're trying to change, or depending on which person we're talking about, the first person trying to change.
I think it's her expectation.
Belief, expectation, psycho, what would you call it? Psychograph? No, not psychograph, but psychology.
It's a new one?
Yeah. I wonder if how important is it, how much can you predict if things, can we definitely guarantee that things will be different in the future? Probably not, but we also can't guarantee that it won't change. So, I mean, do you instill the hope that it could change when in fact it might not, or it might? I don't know. I guess shifting the focus is the only thing that you can do in working on changing that belief. What about, this is just something I think, is it worth seeing another practitioner? Someone else to instill what you've already said, or to, what would you call it, reinforce what you've already said?
Maybe. So the second case is seeing Justin as well. And I had a chat with him about that, and he's, again, going to try and reinforce similar messages. But yeah, I know what you mean. I think sometimes that is worthwhile, definitely just getting a fresh set of eyes on it to give their piece, and maybe they'll understand it better coming from someone else.
What's the surgeon said? Has the surgeon said anything? Is it worth consulting, me back with them?
Yeah, I've had a few conversations with the surgeon.
Yeah, and not much has changed. Yeah, I don't know. That's a great question, though. What else have you got to discuss?
I just had a big high for the week. One of my patients that I might have spoken about on the podcast before has had a raging MTSS, bilateral MTSS, for about 3 years and has been unable to run, or has tried return to running and not really gotten anywhere. And over the last few months of some strength training and gradual return to running, we got him back to his first race last weekend, which was super exciting, felt really good, and it was just one of those really good outcomes that I was pumped for.
Yeah, that's great. Another reason why I guess one of the other drivers for why we are healthcare practitioners, but it's incredible to think how much involvement you played in that. You know, you would almost say you're the main driver of someone getting back to something that they love to do, which is beautiful. It is.
Thank you.
It's good. Listener questions. Should we get into those?
Yeah, let's get into them.
Yeah. So, the question that I had, and this kind of sparked a bit of a cascade on our Instagram story, has the current understanding of load-dependent tendinopathies changed since the continuum? So this person's referring to the continuum proposed by Jill Cook in 2011, and there's been another study come out by Jill Cook and Emily Rio in 2019, which is just a paper about revisiting the continuum. So I've taken a couple of things out of there, but what they were talking about is...
I don't think you've read the question yet. Did you read the question?
Yeah, has the understanding of load-dependent tendinopathies changed since the continuum model?
Yeah, cool. Sorry, I wasn't
listening. Right. So in that, they were saying that in degenerative tendinopathy, interventions influencing tendon structure are less critical, as the pathology appears to have limited reversibility. So in the original continuum paper, they suggested that treatment should focus on stimulating the cell to produce collagen in the degenerative region and to help restructure the matrix. But it's now been demonstrated that interventions designed to change structure don't necessarily result in improvement, but more importantly, they may not need to. So in this sense, degenerative structure doesn't have to change, although it may, and it probably does, to improve pain and function. Now, that's pretty well known, but I thought it's always worth saying, especially in those lines as well. So the pathological tendon appears to effectively compensate for areas of disorganisation by increasing in cross-sectional area to maintain sufficient volume. That's awesome. It is really cool how the tendon, the part that's not degenerative, will change and adapt. And that's what the donut theory, and sometimes you can draw that for patients who are more interested in that. So while the continuum classifies tendons based on the extent or presence of structural disorganisation, targeting treatments at regenerating the area of disorganisation, not really worth doing, as the tendon may have already compensated or be in the process of doing so. So that's why imaging is probably not as important, because if you image someone and find that they do have degenerative tendon, it's very likely that the other part of the tendon that is healthy has probably already changed or compensated, or you can work on changing that.
I think I interpreted that question wrong.
Oh, really? I think they were talking about the tendon. I was talking to this person on Instagram not long ago.
Okay. I won't read my answer then.
Well, yeah, may as well, because
okay.
One of the other questions was discussion on recent advantages in tendinopathy.
The way that I interpreted that question was, has our understanding of load-dependent tendinopathies changed since the continuum model started? So prior to the continuum model.
You hit the mic again.
Now.
Stop hitting the mic.
So my answer to that question was that I wasn't practicing as a physio before the continuum model, so I can't really comment on what the general rehab or management was prior to when the continuum model came out. And the other thing that the other point that I had was that we touched on this with Peter Malliaras in the podcast, and my answer was more so, do we change our management as to if it's a reactive versus a degenerative tendinopathy? And as Peter answered that question through the podcast, that he said that the management doesn't necessarily change. We sort of find what the patient's baseline or tolerance level is and then load them as much as we can for whatever irritability level they're at. So I'm not sure if I answered that question right. Or...
No, that's fine. I mean, any information is good about tendons. They did talk about in that new paper like a hybrid, so they talked about reactive and degenerative pathology, and we're actually having Ebony
reactive on degenerative.
Yeah, so they talk about that, like this hybrid model. But we're having Ebony Rio on the podcast next month anyway, so she'll be able to answer some of those questions. I would say I've got a little bit of confidence, probably better than us. I've seen her present. Yeah.
I'm very excited.
Yeah, she's cool.
Very, very excited.
She's cool. You know, it's just incredible that we get to talk to these people. I mean, I know maybe I express my excitement different to you, express my emotions, and this has been told to me in the past by many people that I do express emotion.
With your eyes.
With my eyes, definitely. With my hand gestures. But I just could not believe Wednesday night when I was going to bed, just sitting there thinking, we get to, for an hour, talk to Dr. Peter Malliaras. More than a year ago, there is no way in the world, even a year ago, that I ever thought that would happen. Like, it's just incredible. The knowledge, so we jumped on the Flexing Physio Dan Chang's podcast, talking about bone stress injuries. I was just pulling stuff out of my brain, not from the sense of, obviously from some things that we've read, but I don't know if you were doing the same, but I was pulling it from things that I've read from Dr. Richard Willey and Stuart Ward and the podcast. I mean, it's incredible. They are the people. It just makes me think that clinicians and people in healthcare are such nice people. They donate their time, their knowledge to help people.
And then we watch YouTube videos of Dr. Gregory Johnson.
I'll have to post him on. Oh, Dr. Gregory Johnson's a chiropractor in the US. He is the antithesis of a good practitioner.
I'm preventing you from getting onto the operating table.
Oh yeah, you definitely got sacroiliac dysfunction, and he's just touching someone's shirt through their back. It's ridiculous. Yeah, we'll post him one day. All right, let's get on to the next question. Come from Sambo up in Tamworth. He wanted to know, why do tendons love isometrics so much? Is there any research behind this? Now, let me pre-frame this. Great question. I always thought that isometrics were great for pain, and then I saw a post from Mick Hughes saying that, or maybe it was Greg Lehman, or maybe it was both of them, saying that the research isn't clear if isometrics are good for pain.
So what I found was there was a recent systematic review that looked at 10 randomized control trials, and it showed that isometric exercise does not appear to be superior to isotonic exercise in the management of chronic tendinopathy. So I had a look at the studies that were included, and throughout the studies they were comparing isometrics to various different interventions. So isotonic exercises, some of them was comparing them to ice, some of them was comparing them to what else? I lost it.
That was a really weird sound you did after that. Sounded like a crocodile or a duck.
Wait, where am I?
Oh yeah, cortical bone stimulation.
No, I lost it. I can't find it.
I knew. This is why I said get prep for the studies. You got to have it on ya. But our poor listeners, they were probably sitting there going, hanging off every word you were saying.
Can we just edit that bit out?
It doesn't matter. All listeners are probably gone now.
Found it.
We said we're not going to edit the podcast. Authenticity.
Found it. Most of them are comparing them to isotonic exercises, actually. So isometrics versus isotonic exercises, some to ice therapy, some to ice therapy and isotonic and isometric exercises, some to eccentric, concentric exercises, and... Can
you just explain, I know most people will know, but just the difference between isotonic and isometric and what we're talking about?
Yep, so isometric exercises are a sustained hold. Yeah. So you're, for example, doing a wall sit for a patellar tendon.
Joint doesn't change in range of motion.
Yeah. isotonic is moving through range with a consistent load or tempo.
Do you think that, because I regularly give, especially in Achilles tendinopathy when they're irritable, I find a place through the calf range where they're not irritable, and I will just tell them to hold. And we know...
Interesting. I find a place where it is irritable and tell them to hold.
Yeah, okay.
So then that found that it was no different, and it was variable across tendinopathy populations. It can be, and this is sort of what I've always thought, is it can be used as part of a progressive loading program. So we take that person and where they're at, and if they can't tolerate a single leg calf raise because it's too painful, then an isometric is a starting point. And then you'd always progress on from that. So it's not the only, like, the end of the road, it's the start of the road in some cases. However, there's another RCT from Ebony Rio, and it's looking at isometric exercises in patellar tendinopathy. And in this study, they have shown that isometric exercises reduce tendon pain immediately for at least 45 minutes post-intervention. They've shown that the reduction in pain was paralleled by a reduction in cortical inhibition, providing insight into the potential mechanisms of what is a driver of pain in tendinopathy, which I'm really keen to ask Ebony Rio about when she comes onto the podcast. So that other study that I was talking about, the systematic review, that one was looking at pain and function. Yeah. This one is more specifically looking at pain. Well, and clinically, I do find that isometrics are useful for the management of pain.
Yeah, I just use it as a bridge.
Yeah, and so do I.
Even just for something, like I think that most practitioners are similar. I just get them to do whatever they can do movement-wise. I mean, I would think, I don't know if this has been done, and I'm saying this purely off what I think, this isn't based in the evidence at all, but I would think that if someone had plantar heel pain and you got them to do some lunges or some squats, they would probably feel better, even though you haven't done anything specific for that heel or that foot, just general movement.
Yeah, just moving it.
Yeah, moving.
In whatever way feels okay to
just
them.
Just moving any part of the body. Yeah, even just going for a swimming, whatever. But it's interesting that movement, because we do know that, we don't know how, but we know movement, or I guess resisted movement, is good for pain. Would we say that? We know that?
Yeah.
Resistance training is good for pain, just purely for pain.
Yes.
But we just don't know the mechanism in which that happens.
Yes.
And it would definitely be, and I'm trying to think of the word, but it would definitely be on a local level, but also a systemic level. So I posted about a couple of studies this week in chronic tendinopathies, the effect on the nervous system and how that can also contribute to some of the underlying mechanisms, that may be pain, function, or possibly even structure. Yeah, it is cool. I just think you can't, when we always talk about it, you can't separate pain, structure and function. I mean, you kind of can, but you can't separate local and systemic pathology or the drivers within that pathology. So if someone has chronic heel pain or chronic Achilles pain or chronic rotator cuff pain, you just can't separate what is happening locally and what is happening systemically. I mean, you can get a bit of an idea, but you just can't seem to do it, can you?
I don't know. I guess if you're talking about tissue healing, we can be pretty confident on tissue healing time frames. Like, we've got
what is healing? Like, is a degenerative tendon not healed, even though it's at full function and no pain?
I was kind of thinking more in like the line of acute injuries.
As an example, I guess
ankle sprain.
Well, what's healed in an ankle sprain? Like, when do you say, yep, that's healed? Like, what is it? Is it the structure? Is it, great, you're healed when you can do 100 single leg hops? But
no, I'm meaning more the tissue.
We'll say for structure then. So what does healed mean? Is it when 75% of the fibers are realigned, or when the scar tissue is formed? Like, what does healed mean? Because people...
That's a great question.
Like, people can function with longitudinal splits in their perineals. does that mean that everyone with osteoarthritis in their knee, your knee isn't healed, even though you've got arthritic structural change, but you're still functioning? That's what I'm saying.
Yeah, that's a good point. I was talking
thanks for that. Thank you.
That's
a good
buddy.
point.
I was talking to a physio about prognosis in regards to when we're talking to patients about what they can expect from their rehab journey.
Mm-hmm.
And we often talk about the relationship of function and pain. So, we often talk about your functional capacity should increase as we go through the rehab process. Your pain will tend to be a bit up and down, and somewhere down the track you'll cross a blurry line where your pain goes down and your function goes up. But we never really talk about tissue, like the tissue healing.
Yes.
And that's been shown to be something that patients really care about, is they want to know if the tissue is okay. So maybe in those diagrams that we're drawing or talking about, we should be explaining that for an acute injury anyways, we can be pretty confident that tissue is going to heal within, at least 3 months for an acute injury. But, for an ankle sprain, probably around the 6 to 8 week mark at most for a moderate one. And just giving them that reassurance that it is going to be okay. Because with the biopsychosocial model, we're so focused on pain and function that we don't really explain the biomedical side of things, as well as patients maybe want to understand it.
Yeah, and the research is clear that patients care most about the biomedical, which is structure, the biological factors.
Tissue.
But... And I don't want to discount the biomedical stuff, which as everything, the pendulum swings, and I'm guilty of that for sure. Like to say that, no, don't care about the structure of the tissue, that's not important. That is not the case at all. It's saying that we should incorporate that in conjunction with the other contextual factors. But I don't know how much we can say, because if you say that to somebody, do they that, not to say they will get focused on structure, but you could almost say that, not saying that structure doesn't matter, but you could say it's not probably the focus for what we need to rely on, because it's a poor metric of how well or how likely you are to get back to 100%, although they are related, but probably not as much as what we think.
I think in some cases it would be worthwhile touching on it just from a reassurance point of view. So people that are worried that they have back pain because their disc hasn't healed, we can say, look, we know that majority of discs will heal within a 3-month period. But this will get better from a tissue point of view, then including your pain and your function and how that will interact at the same time.
Another thing that got me thinking this week is when we say those things to patients' care, we say, hey, the research says this, or we know this. And that's probably from speaking with Dave. Do they really care about that? It's worth mentioning, and I always mention it.
And this is what we talked about last week in terms of that patient that I was telling you about, I started pulling research out, and she didn't give a crap about that.
Well, I guess it would be showing them that. So let's say 2 weeks ago, and this could be a good example, and I've done this in the past with an Achilles where 2 weeks ago they had a 6 out of 10. Now they've got a 2 out of 10 pain. You can say that over those 2 weeks, it's very likely that your tissue hasn't changed very much structurally, although your pain's gone down significantly and you're doing a lot more. So that's what I'm probably saying when I mean that structure and function, structure, how much importance we need to have, how much weight we need to have on structure.
I think the other reason, I don't know, with you saying that, the other reason that I don't touch on it is because how do you know? Like without imaging and things, how do you know that
I don't know, I'm touching on
it is or it isn't healing? Well, I know, and I'm just reflecting out loud. I think that's why I don't do it, is because I just don't have enough confidence to know exactly what the structure's doing. So why even bother? Yeah.
Well, you bother because people care about it. If we know from the research they care about it. But then if we know that they care about it, how do you then explain that it does matter but it doesn't matter if they know that it does matter? And this is a complexity of healthcare. That's
bloody hell.
Yeah. Well, let's finish it there. If anyone knows the answer to that, please shoot it through.
Yeah, I'm interested in that. It's a tricky concept.
Concept, idea, notion. I don't know, Barack Obama would know, but
He'd know the
he'd know
answer to
everything. Anyway, guys, enjoy. I hope you enjoyed this episode
Peter Malliaras,
with Dr. Peter Malliaras.
Tendon Guru.
Welcome back, sports medicine fans, to another episode of the Sports Medicine Project. Now, our special guest today is Dr. Peter Malliaras. Now, in our eyes, definitely the tendon guru, over 120 publications, and someone we have both followed and listened to for some time. I know Kelly's done one of his courses, and I still remember as a student years ago reading your review, Achilles and Patellar tendinopathy loading programs in the Sports Medicine Journal. And yeah, it's a funny kind of reflection point now, getting to think about myself reading that, and now getting to talk to you about tendons is awesome. And that was back when I thought tendons actually needed to be stretched because they were tight. I was a very naive young student, but hopefully we can confirm that that's not true today. Now, I'll give a small introduction for the listeners, but you've been active in tendon research for 15 years, completed your PhD in tendinopathy in 2006, and you've been pretty busy by the sounds of it. But yeah, welcome, mate, and thank you so much for coming on.
Thank you very much, Blake and Kelly. Nice to be here.
Lovely. And so for the listeners, what's your story and what keeps you busy at the moment? I'm definitely sure it's a lot more than what I've put in my very, very short summary.
Thank you, Blake. So basically, I have been a physio for about 25 years, and I sort of worked for a bit, then got into a PhD, and that was probably a bit over 20 years ago now when I started. So I've sort of been in the sort of tendinopathy research in some format for about 20 years, and PhD came first, and then since then I've been sort of mixing practice with research at various places. I did a bit of a stint in the UK, and then since then I've been working here in Melbourne, back in Melbourne, for the last probably, I think, 11 or 12 years. And I sort of combine at the moment. There's Monash University 4 days a week where we've got a group of people interested in tendon research, and a lot of them are PhD students, but also some postdoc researchers. And we do studies ranging from lab studies where we look at things like trying to understand pain and some of the impairments in tendon. And then we also go right through to the spectrum of looking at more translational studies like testing treatments and trials in randomized trials. So we do sort of a spectrum of research, and that sort of is 4 days a week. Then I'm in the clinic 1 day a week, where I'm sort of seeing mainly tendinopathy patients in the lower limb. So yeah, that's sort of the mix at the moment.
Yeah, wow, that's awesome. You had a pretty long history dealing with tendons, and good to hear you see lower limb tendons. They're the best ones. I always joke with Kelly, they're the harder ones to treat. That's why podiatrists are better than physios, but we'll leave that for another topic. I did want to ask and get kind of straight into it for the people, and we're saying off there that we've got quite a lot of clinicians that listen to this, and athletes and runners as well. How would you explain the kind of functionality and basic physiology of a tendon?
Well, a tendon in its basic form is just a rope that attaches the muscle to the bone. And then you've got some tendons that are a bit more specialized that we call energy storage tendons. And that probably the best example of an energy storage tendon is the Achilles tendon. And what tendons like the Achilles do is they store energy, as the name sort of suggests. So they basically act as springs, and that mechanism is really important physiologically for runners as well as anyone that's doing any load-bearing activity like walking, because what it will enable is it will allow the muscle fascicles to work in a very efficient range. So if you think about human movement, and you think about the thing that costs the most energy when we're moving, it's definitely the movement of the fascicles. So how much the fascicles stretch, but also how fast they stretch. So that's really costly in terms of our human movement. So we can't do many fast and large contractions back to back because we get fatigued. So what the fascicles, what the tendon allows is for the tendon to do a lot of the straining and stretching when we're doing things like walking and running, and therefore the calf muscle, the fascicles within the calf muscle don't have to strain as much, and that means that we're much more efficient. So some of the estimates suggest that up to 30% of the energy for walking is passive, based on Achilles tendon energy storage and release. So it's really, really important, especially as we get older. So I see people mainly with Achilles, but as I mentioned, throughout the lower limb, and as we get older, we sort of, walking is one of the key activities that we do, and you need that mechanism to be working well, but also for runners, it's really important tendon function.
Yeah, that's great. You mentioned that you work in a lab as well. Do you do some of your studies on animals as well, Peter?
We don't actually do animal studies at the moment in the lab that I'm in here at Monash. When I was at Queen Mary University, there's some people there that were doing really, really great animal research in tendinopathy. So people like Hazel Screen. I never got to work with her, unfortunately, directly in terms of some of the studies that she was doing, but she's done some really interesting work more recently looking at the interfascicular matrix, which is a part of the tendon that she's discovering enables the tendons that are energy storage to strain a lot and take a lot of energy. So she's sort of discovering some of that. But yeah, here at Monash, mainly human research. We have enough trouble with humans, so I wouldn't want to get into the animal.
I know that. Well, that's why I was asking. I was going to ask if much of the research is done on animals and generalized to humans, or vice versa, or where we know this information from. But by the sounds of it, it's probably a bit of a mix.
Bit of a mix, but we know that whenever you're looking at non-in vivo, so you go away from humans and you go to animals, or you go to cell models or other models, or even modeling work that is really popular now and common, there's always limitations, because you always have to make assumptions, and that is that you can actually transfer what you're finding out in these other models and animals to what we see in humans as well. So it is an advantage to do human research, but sometimes, there's certain things you can't test on humans. For example, some of the studies they do where they, euthanize animals after they've finished certain loading protocols, you can't do that on humans. So there are limitations to human research, but generally it translates better to humans and the people we treat in clinic.
Would you say, and we're talking off air before about a patient that I just had with an insertional Achilles, and we were discussing and they were saying, I wish I could have done something to prevent it from happening, because it's obviously a long journey and it can impact on what they can do. And this person was a runner. Would you say there's any indication for screening people without pain and using particular measures, any of that kind of correlates to an increased risk of injury? Like, as an example, I don't know if it's research or it's more just what I've heard, like being able to do 20 good quality single leg calf raises to reduce the risk of developing Achilles tendinopathy, which makes logical sense, but it might not always translate out like that.
Yeah, it's a really good question. The evidence for risk factors is really quite thin on the ground. There's not much evidence for risk factors. So to be a risk factor, it sort of needs to be tested in a prospective study, which means that you need to have tested the risk factor and then follow a whole bunch of people that haven't got the problem, and then some develop it, and you see if that risk factor is more common in the people that actually develop the problem. And they're quite hard studies to do, because you need to follow big groups of people for a long time. So there's not many of those studies, unfortunately. We don't have a lot of evidence. Having said that, there is some. And if you take the example of Achilles tendon, there's a whole bunch of prospective risk factors that have been identified. And they're some of them are quite surprising, I guess you could say. So I think there was a study, I think it was published 2 years ago or 3 years ago by the Dutch group where Robert Jan de Vos works, and they had they had pulled the data on these risk factors, and I'm pretty sure there was some that were interesting, like, for example, training in colder weather was one of them from memory.
Yeah.
Things like that you
think of.
Yeah, wouldn't necessarily. We sort of tend to think of load as a key factor, and it probably is, but that didn't come out in the analysis, and I think it's because probably change in loading is really important, but no one measures that because it's hard to measure.
Yeah.
People just measure whatever volumes of load, and obviously it's quite individual, the volumes of load we can sustain at any one time. So, and obviously it's also confounded by changes in loading patterns when people develop a problem. So you don't have that in the prospective studies as much, but so load is a hard one to test, but looking at some of the other ones, so for example, fluoroquinolone antibiotics, that's a risk factor. Moderate alcohol use, training in cold weather. I've actually looked up the paper, so I'm reeling them off now.
Yeah.
Decreased isokinetic plantar flexor strength, and that's not a surprising one. So if you've got decreased strength of your plantar flexors and you change your loading suddenly, you're going to expose your tendon to potentially high loads when it's really not up for it. So that's one that is sort of one that we can address. With interventions that we use. But yeah, there's not a whole stack. There's about 5 or 6 known risk factors for Achilles, similar to other tendinopathies in the lower limb. Most of the evidence we have is for what we call cross-sectional studies and cross-sectional factors. And the problem with the cross-sectional studies is that you'd never know whether an impairment has developed after the onset of pain. So there's a whole stack of those. You can't really trust them.
When you say isokinetic strength of the plantar flexors, what's the figures that are coming out for that, or what do we consider to be normal?
It is a bit variable depending on the protocol. So, for example, if you do it in a knee bent position versus a sort of semi-knee bend, so 45 degrees of bend versus a straight knee, it will vary. It'll also vary depending on if the trunk is extended or you're sitting up. So the protocols vary a lot because it just depends on how much force someone can produce. But as a ballpark, I'm pretty sure that in this Matthew paper that showed that it was around about, the torque was around about, and it also depends on how fast they're moving. So it depends on how fast, because with an isokinetic dynamometer, you can move at sort of 90 degrees per second, or sometimes much faster than that as well, up to 240. So it depends on speed. I wouldn't want to guess off the top of my head, but it was a fair difference side to side. And I guess one of the ways that we look at it is how big is the proportion of difference side to side. And if it's more than 10%, then it's starting to, think about a more substantial difference. But we've actually got some data to answer that question with a different test. One of my PhD students, Igor Sancho, has just actually finished and actually been awarded his PhD. One of his studies was looking at strength measures all throughout the lower limb in people with Achilles tendinopathy, but we just compared them to people that didn't have Achilles tendinopathy and also to the unaffected side because they all had unilateral. And what we found is that the one that was impaired the most was seated calf raise 6RM.
Right.
Yes.
I think I might have seen that. Has that been published?
It has, yeah. It was published just late last year.
I think I saw that on your Twitter. Did you share that on your Twitter? I think I've got a screenshot of that on my phone.
I did. I shared it on Twitter. I also wrote a Talking Tendons podcast about it. But we sort of found that if you've got impairments, most people can push 1.5 times their body weight. So if you weigh, say, 70 kilos, you should be able to push 105 kilos for 6 repetitions of a seated calf raise in a Smith machine. what we found is that the people who had Achilles tendon pain, and they were all runners, so they were still able to run, they were able to push more like 1.1 times their body weight. And that was by far the biggest impairment that we found. We looked at glute strength, knee strength. We looked at also standing calf raise.
Yeah.
So that was interesting. So we do know that it's impaired, but again, if we look prospectively, we're not sure if that develops after, and it probably does for some people, rather than sort of preceding the tendon pain.
Yeah, interesting. God, I'm in a bit of trouble. I weigh 100 kilos. I don't know if I can do 150 kilos calf raise. I might break my knees, but we'll see.
Well, most people, because I test it routinely in the clinic, most people struggle, even on their good side. So a lot of people are not at the level that healthy runners probably should be at. One of the problems is we don't have a lot of normative data for a lot of these tests that we do. So it was good that Igor was able to really get some data for at least that one.
Yeah, that's great.
Is that typically from like plantar grade as well, or is that looking at dropping down off a step into a bit more of that dorsiflexion?
Yeah, dropping down right down into dorsiflexion. So we didn't actually do it over a step, but with the seated calf raise, what we get people to do is just shift their heel back when they're in that sort of down position, and that allows them to get a lot of dorsiflexion. So if they slide their heel back, rather than having the tibia vertical, the tibia is angled backwards, and that sort of gets them into near end range dorsiflexion.
On that topic of and talking about kind of heavy calf training, and I know Greg Lehman and Dave Renfrew, some previous guests on the podcast, has been talking about what tendons need to get better when they're painful, and kind of the general assumption is they need heavy resistance, but there has been a study, and correct me if I'm wrong, to show that they can get better with medium and high loads, and there wasn't that much of a difference. So do we understand that tendons need mechanical force, I think, to get better, but does it need to be heavy? Does it need to be challenged, or it just needs to apply mechanical force and we get that adaptation?
Yeah, that's a really, really, really good question, because it's a complicated one. If you look at healthy tendon and how it adapts, the most important mechanism that we know about at the moment for healthy tendon adaptation is straining the tendon. So the more force you put on a tendon, the more it's going to strain, and therefore the more it will adapt. So if you're thinking about the outcome of healthy tendon adaptation, it definitely is important to strain a tendon with high force, so higher intensity is better. Now, when you're thinking about a clinical context, that's different, because now we're dealing with someone who has pain and a tendon that needs loading as well and adaptation, but they've also got pain. And what the literature shows really clearly is that in terms of improving pain outcomes and a lot of self-reported outcomes, even self-reported function disability, it doesn't actually matter if we do heavier load. So if we load them more intensely, or we do lighter load, those outcomes will still improve, and they improve it in the same way. So we've done a few studies. One of my former PhD students, Fatma Asani, she did a study where she looked at 4 different loading protocols for the Achilles, and it was just a pilot and feasibility study, but she was able to show that if you look at the effect sizes for high load and low load interventions, they were pretty similar. So there wasn't much in it. Another student, PhD student who's close to completing at the moment, Josh Norton, he's done a similar study looking at shoulders, and he's also found the same thing. So it seems really clearly that it doesn't need to be heavy to improve pain. But we do think that heavier loading will probably improve ability to perform certain functional tasks that require higher loads, and it will probably also improve tendon adaptation. But the catch to all that is that if you look at studies, and there are only a handful that look at tendon adaptation for pathological tendinopathic tendon, you don't tend to get the same adaptive response with a stimulus that would adapt a normal tendon, healthy tendon. So
God, that makes it so complex. More.
It does. It does. Yeah. It sort of makes your brain hurt a bit because you sort of think you're doing all the same things, but the tendon doesn't actually adapt. Maybe we need to do longer duration interventions. Maybe instead of 12 weeks, like healthy tendon, we need to do it for, 26 weeks or a year. Maybe we need different interventions for pathological tendon. We just don't know yet. But or maybe the outcome measures that we're using are not good enough. So the main outcome for tendon adaptation is the amount of stiffness of a tendon. So it's the amount of stretch for a given force. And that outcome might not be sensitive enough to show different adaptations that are going on in the tendon, not on that sort of global stiffness outcome that we're using. So it's a complex area, but generally as a clinical rule of thumb, to be able to provide some clinical guidance to people. And what I tend to do in clinic is I will sort of adhere to the principle of you do want to do some loading that is higher intensity. At least one or two exercises of getting up to higher intensity is probably a good principle from a point of view of adaptation of the muscle and tendon. It's probably the way to go, even though you don't necessarily need to do that if you are just focused on pain as an outcome.
And is that, when you say higher intensity, is that the rate of loading, or in regards to strength, or both?
High intensity would be sort of greater than 70% of MVC if you're doing isometric, or greater than 70% of 1RM. So you're looking at fatiguing them, by about 10 reps or something like that. Yeah.
Wow.
And then
that's funny. Just when you think a little bit, you don't really.
I mean, we kind of touched on this throughout that, Peter, but why don't we rest tendons? I know previously we used to think rest was the answer, and now we know that loading is probably more likely the answer. Do you think that there's any possibility it could go full circle and we could end up wanting or thinking that we need to rest tendons again, or do you think there's enough evidence to support loading for improving tendon adaptation?
Yeah, look, that's a really good question. Interesting area. So if you go back to the 70s, we would say to people, you've got to rest because it's inflamed and it will settle down. At that time, they were also cutting out bits of pathology in the tendon because they thought it was as simple as if you just take out the pathology, the tendon will feel better. So we had a very simplistic view that was based around pathology equals pain. The pathophysiology is inflammation, just got arrested, which we know is not right now. But I think we have got now into a period where we want to be active in our interventions. And the main reason for that is we know that if you're not active and you stop being active, your pain can actually get worse rather than better. So you go into a cycle where you become deconditioned, tendon becomes weaker. You also, and a lot of these people also have psychological sort of associated factors like, poor self-efficacy and high fear avoidance. So that type of patient, it should be encouraged and reassured to be active regardless of a little bit of pain, and that they'll probably do better if that's the case. But there is, as you've alluded to, a limit to the sort of mantra of we should be active regardless of what's going on. We do need to be careful. Sometimes I think with the situation where you've got someone who's really, really irritated and flared up, and they do need rest, in inverted commas. And rest might be just reducing loads really substantially for a certain period of time. So that still is important for some people, depending on how much pain they have with the day-to-day things they're doing. And then you've got other people who, really are sort of, you might be doing exercise and rehab with them and they're just, flaring up or having a pain response that is beyond what would be acceptable. And that, the thing that we tend to call acceptable is an increase in pain for a short amount of time after loading or some activity is okay. And those people, again, you might need to adjust. So it's sort of a constant process of trying to, the way that I sort of try and explain it to patients is you've got the ability of the tendon to take load, and that could be day-to-day walking plus running plus the exercise we're doing. And then you've got the amounts of that loading you're doing. And you've just got to find the balance between those two. And sometimes it involves rest completely. Sometimes it involves a trade-off. Sometimes it involves no rest and continuing or even increasing the amount of loading they're doing, depending on how they present. So if they present with a lot of pain, you're probably going to reduce loading. If they present with not much pain, some people present with not much pain, but not much activity either because they're fearful. And then it's reassurance and trying to get them active. So it really does depend on where their starting point is.
How do you explain, and you've definitely answered it there, like when people talk about, tendons becoming irritable, and we're very much, I know Kelly and I are very similar in the clinic, trying to de-threaten the pain and saying it's probably not the best measure of the tissue health when the tendon's been painful for a long time. And I'm imagining, an Achilles tendinopathy that's been sore for 2 years, as we start to do more, yes, it can be sore, but it's probably more related to the sensitivity than real pathology in the tendon. Do you find that's the case, or how do you explain that to patients when they are a little bit fearful and they're worried that they're doing kind of more damage, and it's okay to have a little bit of pain with the rehab?
Yeah. Look, I think just simple messages like making sure that they're clear that it's not, so pain is not a sign of damage or further injury. It's okay to feel a little bit of pain. And then that might be enough for some people. So just the reassurance that it's okay to feel pain with certain activities, you're not going to rupture it. It's not going to get worse in terms of the pathology that's there. That could be enough for some. Other people, you might go down more of a pain neuroscience explanation where you sort of then explain further about, it is okay to load a bit because we know the pain is not related to structural tearing or damage. The pain is probably related to a biochemical response in the tendon, which is separate to what's going on from a tissue point of view. It's more of a cell response, but also it's influenced by so many other factors in their day-to-day life, like how much they sleep and how attentive they are to the pain and fear and all these other factors that we know about in the biopsychosocial model. So, so then just you might go, more towards a pain neuroscience explanation for some people. If they sort of are thinking, if you're thinking this person wants a bit more, or they'll benefit from that level of explanation. So it can be quite individual, but I find most people are pretty reassured when you say to them, look, it's completely fine to have a little bit of pain, you're not damaging it. It's sort of an intuitive thing, I guess, for most people where they find that level of detail is enough. You don't need to go necessarily to pain neuroscience education.
Yeah. Kelly, you're looking at me.
I just had one question. You mentioned the biochemical response within the tendons. Could you elaborate on that? That's probably just me being
surely that'd take like 5 hours, I'm sure.
No, it's quite simple because my understanding of it is quite simple. I can tell you I'm not a cell level researcher, but there's a lot of stuff that's been looked at in terms of the cell response. And generally and there's a really good paper written by Neil Miller and his group in Europe, the UK, about the sort of pathophysiology understanding at the moment. It was in Nature Reviews. But basically, the thinking at the moment is that you've got a whole host of cell changes. So you've got all these cytokines that change in terms of their levels within a tendon, and they're basically driven by probably excretion and from the cell, but also some of the local nerves that are in the tendon. So things like substance P, calcitonin, germ-related peptide, but also growth factors like vascular endothelial growth factor, and they cause changes in immune system level, but also neural function within the tendon, and they may then contribute to some of the pathology and pain changes. So the thinking is that you've got a whole host of really complicated sort of cell and neural and immune changes that happen within the tendon, and that sort of sets up that environment of pain and sort of change in the tissue itself.
And is there something in that leads us to understand why pain is typically after loading?
There are a few theories about that. And it could be that you have a delayed response from the tenocytes within the tendon, and they then start to signal, and you start to get changes in pain. So there are a few theories, but I don't think we have anything definitive about what's going on with that pain behavior.
Ellie, you're asking some tough questions. That was a good question. I feel bad now. I've just got a pretty simple question, but something that we talk about a lot and learn about, especially in the podiatry profession, is kind of a big no. You never do it. You never inject a tendon. But asking it yourself, have you seen, and when you've managed them over the years, like, do you think there's any indication for injectables, and whether that be PRP or cortisone or prolotherapy for tendons at any stage, and thinking end of the spectrum of someone that they're irritable, they're really struggling to move and really can't do much at all? Is there ever a stage where that might be an indication?
Yeah, look, I sort of have to answer yes to that, because I'm currently leading a trial funded by NHMRC investigating an injection for Achilles tendinopathy, and that's the high volume injection. But I think injections generally, if you look at the overall, there's probably three main ones. There's steroid injection, there's PRP, and there's also the high volume injection, which is high volume of fluid with some steroid and local anesthetic. And none of them have got, I think it's fair to say, a strong evidence base supporting them. So I think that's why people have, I guess, gone away from injections, or not really been keen to go there unless it's a real last resort. Having said that, they are really commonly used, and if you've got someone who's failed lots of interventions, they're very, very commonly recommended at that point. My personal view on things like steroid or PRP or even high volume is that for the right person at the right time, they're probably all possible as something you'd recommend. So my practice would be to try and inform the patient about the risks and the benefits for each one. So we know that with steroid, there is strong evidence for short-term benefit, but there are question marks over longer-term harm. So in the longer term, you might actually get a recurrence of your pain. With PRP, we know there's strong evidence that it doesn't work compared to placebo. But even when you tell that to some patients and they've tried everything, because anecdotally some people get a response, they might have had a friend or someone they know has got a response, they might be still keen to try it. And then you've got the high volume injection, which is still developing in terms of its evidence. So there's not really any good trial evidence. As I said, we're doing a trial at the moment. We've recruited 192 people with Achilles, and we'll publish the findings of that over the next 12 months. We don't know the findings yet. We haven't looked at the data. We're still waiting for 12-month follow-ups to come in, but that will help us in terms of how we sort of think about injections. But still, we don't have a strong evidence base for injections. So I don't think they should be considered as, never do an injection. But I also think they are overused massively in terms of clinical practice all over the world. And I think it's because patients perceive them as something that might help them and be easy to do, rather than what we generally recommend, which is really hard to do, and that is exercise over several months.
Yeah. Have you found, so where I work with a bunch of sports doctors and sports physicians, and injectables are are a common practice, and like you said, at the right time, it can really change people's lives. And I've seen people where it's completely taken away their pain. Now, obviously, that's not everybody that has an injection, but seeing it does work in those cases. I looked for a long time to try and find any research that having cortisone to the Achilles increases your risk of rupture, and I couldn't find anything. Only heard anecdotal stuff from the doctors and other people. Have you heard anything about that?
In terms of rupture for steroid?
Yeah, like having a rupture after having an injection, like it increases your risk significantly.
Yeah.
Yeah,
So I have seen a few people who had steroid and then ruptured after, and
yeah.
pretty quickly after. And it does happen with steroid. I think the key factor is where you put the steroid.
Mm.
So if you put the steroid into an Achilles tendon, you massively increase the risk of rupture. If you put it around the tendon, my anecdotal experience is that